Bismillahirrahmanirrahim. This video will describe the pathology of the osteoarthritis. Following are the references of this video. The classical clinical scenario for the osteoarthritis is a old woman present to your clinic complaining of stiffness and pain in both of her knee. Upon further questioning, she tells you that the pain becomes worse later in the day after she has been walking around. Then the classification of osteoarthritis, you can divide it into primary and secondary type. The primary type of the osteoarthritis is due to destruction of the joint, which result from intrinsic defect in the articular cartilage itself, and it can be of generalized type and localized type. Generalized type is generalized osteoarthritis. This is generalized osteoarthritis, and it it encompasses the generalized osteoarthritis with Heberden nose, then erosive osteoarthritis, endemic osteoarthritis, and osteoarthritis of inborn type that is associated with type 2 procollagen defects. Then there are localized type. The localized type are only localized only to a single joint, such as hip, knee, or spinal facet joint. And there is also a term that is chondromalacia patelli. And this chondromalacia patelli, it is a term in which the osteoarthritis affects the patellar surface of the kneecap. It affects the younger individual and also termed as Herner's knee. Then the secondary type of osteoarthritis can be divided into various groups. In group 1, there is crystal induced or crystal deposition, such as in the hyperparathyroidism, hemochromatosis, Wilson's disease, gout, calcium pyrophosphate deposition disease, basic calcium phosphate deposition disease, and oxalosis. Then there is group 2, that is subchondral, that is due to this group 2 is concerned with the necrosis and abnormality of the subchondral bone, such as aseptic necrosis, Lippincotts disease, and slipped capital femoral epiphysis, post-traumatic osteoarthritis, Paget's disease, and steroid arthropathy. Group 3 of the osteoarthritis is due to some underlying cause, such as abnormal joint laxity, as happens in Ehlers-Danlos syndrome, osteogenesis imperfecta, and Marfan syndrome. The group 4 includes abnormal cartilage growth and function. There are a lot of disorders such as acromegaly, achondroplasia, spondyloepiphyseal dysplasia, multiple epiphyseal dysplasia, congenital hip dysplasia, mucopolysaccharidosis, ochronosis, and diabetes mellitus. The group 5 includes the destruction of the synovial cartilage and bone, as happens in post-inflammatory osteoarthritis, post-infectious osteoarthritis, and also happens in hemophilic arthropathies. After seeing this long list of the classification of osteoarthritis, we can infer that there are many local and systemic factors that are responsible for the development of or development and progression of the disease, and this determine the site and severity of the osteoarthritis. Age, sex, and ethnic characteristics are linked with disease. The age is very important phenomenon, and as you know that as the age advances, there is increased susceptibility for this disease, and this disease is very common beyond the age of 50. 40% of the cases, 40% of the individual who are beyond the age of 70 have this disease. Then the bone density estrogen replacement therapy for postmenopausal nutritional factors, genetic factor, all are attributed to the development of this disease, and these are the risk factors for the disease. Then local biochemical factors are also important. These are obesity, joint injury, joint deformity, sport participation, muscle weakness, which decreases the support to the joint, and all these contribute to the development of osteoarthritis. The etiological factor for the osteoarthritis are increased unit load, resilience of the articular cartilage, and stiffness of the subchondral coarse cancellous bone. There are many reasons for the increased unit load. So abnormal force on the cartilage may have many causes, but often attributed to the incongruities of the joint. Thus, in congenital bone dysplasia, a fairly common abnormality, there is the socket of the acetabulum is shallow, and it covers only 35% of the femoral head, that is normally covered 50%. So less surface area is covered by articular cartilage, which then bears an increased load. When the critical unit load is exceeded, the chondrocyte death occurs, and it causes the degradation of the articular cartilage. Then resilience of the articular cartilage is another etiologic factor. Because these articular cartilage bind extensive amount of water, it normally has a swelling pressure of at least 3 atmosphere. Disruption in water bonding leads to decreased resilience, so predisposes to the osteoarthritis. Then stiffness of the subchondral coarse cancellous bone is another factor. The structure of the bone that is adjacent to the joint is important in maintaining articular cartilage. Mechanical forces are not transferred to articular cartilage by normal stress, but rather are dissipated by microfracture of coarse cancellous bone. Damage to this structure results in an increased unit load on the cartilage because of an increase in the stiffness of the subchondral bone, as happens in Paget's disease. The morphological lesion of the articular cartilage result from degeneration or disordered repair of the articular cartilage, which are due to the chondrocyte injury, and this chondrocyte injury is by biochemical stress or genetic pleomorphism, which lead to abnormal signaling mechanism or signaling transduction mechanism. And due to this chondrocyte injury, the proteoglycan synthesis is destroyed, and there is continuous formation and degradation of the proteoglycan in that area. When there is decreased synthesis and degradation is more than the proteoglycan composition or formation uh, is changed, and result in osteoarthritis. Chondrocyte injury also lead to transforming growth factor beta secretion, and through this secretion transforming growth factor beta secretion, and this beta mediated matrix metalloproteases secretion, there is increased degradation of type 2 collagen network, and there is also other soluble mediators that are liberated, and these are TNF, prostaglandins, and nitric oxide, and there is also low level of inflammation, which contributes to the insidious nature of this disease due to alteration in the matrix. So this imbalance between the synthesis and degradation of the cartilage matrix is due to increased degradation by pro-inflammatory cytokines, matrix metalloproteinases such as collagenases, stromatolization, gelatinases, aggreganases, prostaglandins, and nitric oxide, and the synthesis of anti-inflammatory cytokines, tissue inhibitors of matrix metalloproteases, growth factor, collagen synthesis, and proteoglycan synthesis are decreased. So an imbalance is created, and this lead to predisposition to the osteoarthritis, or this contributes to the development of osteoarthritis. So altered by many factors, these chondrocytes, which is linked to a cornucopia of matrix elements, this chondrocyte is pushed to the plethora of abnormal cellular response, which are made by changes in metabolism or phenotype. Number of cell is also altered by proliferation or suicidal or programmed cell death of these cells, that is apoptosis, and also due to senescence. And all these contribute to the dysfunction or loss of function of chondrocyte. Now, if we summarize the pathogenetic events, there are some genetic influences, also some acquired risk factors. The genetic influences are biochemical abnormalities in the collagen, proteoglycan, and bone formation, or the abnormalities in the congruity of the joint surfaces, as happens in congenital hip dysplasia, or the acquired risk factors such as age, obesity, metabolic conditions, malalignment, or joint trauma or injury, which lead to structural damage to the cartilage, and this in structural damage to the cartilage which alter the function of the chondrocyte, as we have seen earlier. And this chondrocyte dysfunction will lead to release of or alteration in the matrix metalloproteases, and there is degradation of the collagen and proteoglycan also. Also, there is muscle weakness present, and both these factors can subsequently further damage and lead to further lead to the articular cartilage dysfunction. There is release of cytokine also, and these cytokines are released there, and they are responsible for the inflammation of the synovium and remodeling of the bone. So remodeling can further contribute to the muscle weakness. So injury to the cartilage, it will result in cracks development in the cartilage, and there is subsequent accumulation of the chondrocyte, and there is release of enzymes that occur after this development of the chondrocyte or aggregation of the chondrocyte, and as a result there is breaking of the matrix, and matrix is broken down, and due to this matrix degradation, more cartilage is damaged. Simultaneously, due to release of various cytokines, the synovial membrane is also thickened, and it is inflamed. It is inflamed, and it also takes part in the damage to the cartilage, and it is responsible for changes in the chondrocytes also. Cytokines are also responsible for thickening of the bone, and these are also responsible for proliferation of the blood vessels, and As a result, uh, when there is more cartilage damage, the contour of the cartilage is also disturbed, and it is disorganized or unorganized cartilage over there are formed. So subsequently, there will be development of osteophyte, that is the bony growth or bone spur formation. Prevalence and severity of primary osteoarthritis increases with age. About 4% of the people between the age of 18 to 24 years are affected, while 85% of the people between the age of 75 to 79 years are affected. The disease is more common in men before the age of 45 years, and it is more common in female after the age of 55. In men, the most commonly affected joint is hip, while in female, the more commonly affected joint is knee. Now we will see how this osteoarthritis evolves. Here you can see a normal joint with healthy cartilage and healthy bone. With the development of arthritis, there is development of cracks initially. There is development of cracks initially in the cartilage, which subsequently lead to formation of loose bodies within the uh, joint due to sloughing off of the whole thickness of the cartilage, and the cracks are now more deeper. There is more deepening of the cracks and development of microcyst formation. Cyst formation due to whole thickness loss of this articular cartilage and subsequent accumulation of the synovial fluid within these cracks, and which these cysts deepens and they form cyst. Joint capsule, it is affected lately in osteoarthritis. So finally, the bone and the joints can seriously and permanently deform, and there is almost complete loss of articular cartilage. So now histogenesis of this osteoarthritis. Here in the left diagram, you can see that some of the chondrocytes are dead. Some of these lacunae are blank, and these empty lacunae are denoting the death of the chondrocytes. And as a result, the surrounding chondrocytes, some of the chondrocytes, the surrounding chondrocytes, they are viable and they aggregate, enlarge, and now become surrounded by basophilic material, which is termed as territorial matrix. Basophilic material, that is territorial matrix. The process can be arrested at this stage for several years, but and all this is happening above the tide mark. So the process is arrested at this stage for several years, but as the predisposing factors are there, so it can lead to the next step, which is the formation of early cracking and fibrillation of the cartilage. In fibrillation, there is development of surface cracks. There is development of surface cracks parallel to the long axis of the articular cartilage, and it is termed this fibrillation. It is still limited above the tide mark. The concept of the tide mark we have discussed already. So here aggregates of the chondrocytes are present, aggregates of the chondrocyte present, and fibrillation progresses. So there is loss of articular cartilage. These articular cartilage and the articular cartilage can go to the synovium and start an inflammatory process in the synovium, and now this defect that is present, it is vertical, and it is in the long axis of the, it is vertical to the long axis of the articular cartilage, and due to this defect there is hypertrophy of these surrounding chondrocyte, as we have earlier seen, and now this defect is going down, and it has gone beyond the tide mark. It has gone beyond the tide mark, and a whole thickness of the cartilage, and this cartilage has removed, and loose bodies may form within the joint, or the bone is also reabsorbed. Bone is also reabsorbed. Due to some of the part of the bone, they start resorption due to osteoclastic activity, and as you know, there is simultaneous osteoblastic activity and osteoclastic activity. They both go hand to hand, and due to these activities, the underlying bone is going to be thickened. When there is vascularization of this area, there is accumulation or infiltration by the mesenchymal cells. Then they differentiate into fibrocartilage plug. So this fibrocartilage is unstable mechanically, so it disappears progressively, and the underlying bone is exposed, and this underlying bone is thickened, and if there is any crack in the bone, there is leakage of the synovial fluid, which initiate the formation of subchondral bone cyst. Focal regrowth of the articular surface will result in osteophyte formation. The osteophyte, which are also termed as a spur, are pearly grayish-white bone nodules, usually on the periphery of the joint surfaces, and formed by differentiation of the mesenchymal tissue into the osteoblast and chondroblast. They produce characteristic clipping pattern on radiology. The osteophyte of the distal interphalangeal joint are termed as Heberden nodes. All these pathogenetic mechanisms, they lead to characteristic morphology of the osteoarthritis, that is, fissure or crack formation, presence of loose bodies, eburnation of the joint surface, formation of microcyst, presence of osteophyte or spur changes, and the proliferation of the chondrocytes, decrease proteoglycans, increase water and collagen type 2 degradation. They results in granular and soft articular surfaces. Loose bodies are formed due to full thickness sloughing of the cartilage. Then eburnation is due to friction of the joint surface. Exposed joint surface is now eburnated, and it is shiny articular surface basically. Microcysts are formed due to collection of the synovial fluid that is present within the gap that are formed, and a small flexure inside. And osteocyte we have earlier discussed. These are due to groups of the chondrocyte. They then differentiated fibroblast. They form fibrocartilage and hyaline cartilage that gradually ossify. Then finally, the synovium is also affected, and it is affected late in the osteoarthritis. There is mildly congestion, fibrotic, and few inflammatory cells are also present in the synovium. This is the gross appearance of the joint articular surface that is showing eburnation. There is on your extreme right, there is some remnants of the articular cartilage, and two evident subchondral cysts are there. Here, this is subchondral bone. This is the gross picture of a femoral head that is excised, and here you can see that there is development of an osteophyte over here. This is osteophyte, the spur or bony projection, and then there is a subchondral bone cyst, presence of this subchondral bone cyst, and the surface is eroded. This femoral head is showing a prominent osteophyte with widening of the head margin, and in this picture there is rough eburnated irregular appearance of the eroded articular cartilage. So these illustrations are showing the summary of the morphological changes that are due to osteoarthritis. The articular end, they become flattened due to cartilage damage. The joint space become reduced. Frequent presence of osteophyte or bony spicules or bony spurs, presence of loose bodies which may result in crepitus, and then the microcyst formation which is present in the, and there is also subchondral bone cyst. So histology of osteoarthritic cartilage is described in this photomicrograph. This is the normal one, and here you can see in the osteoarthritis two characteristic feature of cartilage in osteoarthritis are fibrillary fissuring and clustering of the cells in the superficial zone. This histological picture from a femoral head is showing the presence of fibrocartilaginous plug and eburnation of the bone. This is the photomicrograph of head of femur, and it is showing thickening of the uh, subchondral bone, focal absence of the articular cartilage, and uh, in this area there is presence of subchondral bone cyst. All these morphologic changes are evident by the radiology. As this X-ray, this is showing the hip joint with narrow joint space, subchondral sclerosis, scattered oval cyst, and a peripheral osteophyte lipping, which is marked by this arrow. And here, this is a knee joint, and there is a narrow joint space, subchondral sclerosis, and lateral osteophyte formation in this picture. Here, these are radiographs in osteoarthritis. Here you can see that there is narrowing of the joint space, and there is greater lateral widening in distal interphalangeal joint, while subluxation of the distal interphalangeal joint is also seen over here. This is the base of the thumb, and it is showing marked osteoarthritis. Then here in the hip joint, there is joint space narrowing is seen in osteoarthritis. Patient of osteoarthritis is usually an old-aged man or woman. If the sign and symptoms are present in the younger individual, the underlying cause for the osteoarthritis must be sought. The symptoms and sign can be mild or severe. The joint is enlarged, tender, and boogy. It is painful, and there can be knobby bony growths present in the finger, and loss of cartilage in the joint will result in pain, which is deeply achy pain. This pain versus this pain, it will worsen. This pain, it get worsen with the moment. There is morning stiffness in the joint, but it relieves after some time with activity, and there is swelling of the joint also. Then there are effect by the osteophyte, and in which in these osteophyte there is nerve root compression, which result in radicular pain, spasm of the muscle supplied by that particular nerve, atrophy of the muscle, or neurologic defect. Then there is a limitation of the joint movement. Joint deformity can develop over time, but fusion usually doesn't occur. The commonly affected joints are hip, knee, lower lumbar, and cervical vertebrae. Proximal and distal interphalangeal joint of the finger, first carpal joint, and first metatarsal joint are also affected. The few joints of the body are spared by this osteoarthritis. These are wrist, elbow, and shoulder. For the treatment of osteoarthritis, the aim is to manage the pain by non-steroidal anti-inflammatory drug, which reduce inflammation also. Intra-articular corticosteroids are also used. Modification of the activity by the person if the joint is disabling, and then arthroplasty can be performed. There is no way to prevent this disease, but it can be delayed by increasing the support to the joint by physical activity, which increases the strength of the muscle around the joint to stabilize them, and to move the joint, or to move the joint to their full extent and decrease the workload. This is the clinical scenario we saw in the start of this video. The 67-year-old woman present to the clinic with stiffness and pain in knee, and the pain worsens in the day after she walks around. On physical examination, there is bilateral swollen knee with mild joint effusion and crepitus with flexion. You also notice bony nodule on her distal interphalangeal and proximal interphalangeal joint. X-ray shows reduced joint space and presence of osteophytes. Thank you for your attention.